here. Hi, everyone. I'm glad that you were able to join today. We're going to have a pretty good discussion here on care team communications, but I'm really going to try to zoom in on transitions of care. So this is a companion webinar, and it's supporting a previous discussion that happened a couple weeks ago that was more clinically focused. It was more aligned with what care teams should be doing and deploying to improve transitions of care, but it's all centered around high reliability, the journey that many of us are on, the behaviors that are expected from that, the role of communication, and how transitions of care is really going to be one of these hot topics over the next several years that if we're not paying attention to now, we need to be. So I'll go ahead and get started here. Some of the material is going to be a repeat of what was previously spoken about, but not in an exact way, but just enough to kind of lay the landscape for what we're going to talk about. But I have 4 objectives for today's agenda, and the first would be an overview of modern medicine and starting to talk about what those rules are and the role of patient-centered care. And so I assume most of you on the phone today are familiar with this, but we'll revisit it as a way to refresh our minds into what it means for high reliability. And we will cover what high reliability is, extremely high level. If this is a subject that you're interested in or a journey that you're on in the organization, you're likely aware you can go very deep on this issue. It's a highly complex but an exciting movement in healthcare. Then we're going to spend a bit of time on care team communication and the role of that in transitions of care and the impact of that as it relates to outcome and cost, and the big snowball and domino effect that is perpetuated when communication breaks down and transitions of care are poor. And finally, we'll just kind of try to put all this together so it makes sense for you to carry forward in your day-to-day operations. So the first is about patient-centered care, and I always like to say that we've been talking about patient-centered care for a long time. It's not a new concept, but many organizations didn't deploy a true patient-centered care model, even though it was known to be best practice. And that is really because it wasn't tied to reimbursement. It was a good idea, it's a nice idea, but gosh, it takes a lot of effort. It takes a lot of cultural transformation in where authority lies and where power lies within the organization. And so from my experience, a lot of places talked about it, a lot of places wanted to be patient-centered, but operationalizing that and actually measuring whether that was so wasn't so true. So when you look at patient-centered care, you kind of look at the patient being in the middle of the model and what lies around it in the different layers. And so I like to look at it in 3 layers, and that's the macro, the meso, and the micro system. And I've put out here a few examples of what the macro system would look like and the things that are associated in the macro system. And you can look at that and think of it as those are the most broad, most farthest away things from patients as possible. But however, in old models, these are the things that really drove what we did. How many of you have heard that we have to do this because the Joint Commission says so? Or we can't do this procedure, or you can't stay here more than 3 days because your insurance company says so. Or we're focusing on these particular metrics because they're in the value-based purchasing program. Well, that is true. A lot of that is true. But what you'll find in a patient-centered model is while these influences are there, they're not determining care and decisions in silos. They're even starting to change their model a bit to have their regulations and elements of performance more closely aligned with what the patients need to have the best care possible. So the next layer on the patient-centered care model would be that MESA system. And we're getting a little bit closer to the patient now, because now we're actually within the reach of their environment. But this is really still not within their microsystem. It's talking about the infrastructure of IT that exists in the places they're getting care, the access points they have, the networks of their providers, and the leadership teams that take care of them. But the farther we go in, we finally get to that patient microsystem. And this includes their family, their caregivers, their own home environment, and really is the place where the real value happens. And in a patient-centered care model, it is in the center of the model that is driving all decisions, and it's the center that supports all the other higher models and not the other way around, which is why it has taken us so long to actually deploy patient-centered care. So with the expectation of having a patient-centered care model, naturally we have to adopt a new set of rules. And this is a graphic here from the Institute of Medicine. I have hand-selected some of them. There are more rules on their website. But you can take a look at what traditional rules would look like, and some of that is related to very individual-focused behaviors. So professionalism and professional autonomy drives variability in care. So these are those clinicians and providers that are more concerned on prestige than they are of customizing their care to meet the needs of their patients. We also look at traditional models and traditional rules as looking at the information that's collected in the hospital as a record, the record of care, and the hospital owns it, or the healthcare system owns it. And in a modern care model, we know that we desire for knowledge and information to flow freely through the system, and the patient owns their data. The patient owns what happens to the data, and the patient should have access to that data. The other things that I just want to highlight on this slide is in a traditional or old school way of doing things, preference is given to professional roles. And really in this modern world, we're talking about interdisciplinary care, where we look at integration among clinicians as being a priority. And interdisciplinary care, I just want to spend a moment on this, is different from multidisciplinary care. So in a multidisciplinary care model, you're acknowledging the fact that there's multiple people on the team and that each one of those disciplines has goals for the patient, has their own care plan for the patient, and you're acknowledging their existence. But in an interdisciplinary team, the goals are shared among all disciplines. And you're all working together towards the same goals, and you acknowledge the unique contributions of each discipline into the care model for the patient. So you're not working as bubbles next to each other, but it's an integrative model where everyone's working together towards the same set of goals, and it's a lot less handoffs that way. So I'll move forward here. We now know the expectations for patient-centered care, and having that expectation in place just organically changes the rules of the game. And when the rules of the game change, magically, organizations begin to behave differently. And this is where we kind of get to that high reliability state of mind. And I want to mention that, you know, many places that are starting to talk about becoming a high reliability organization talk about it in terms of a landing pad or an achievement or a place to be or something to acquire. And that is not what high reliability is. High reliability is a state of mind. It's the way you behave. It's a cultural feature. And it's an evolution. And it's not something you complete and you check off and you move to the next trend that we find in discussion. It's actually a business model, and it is the way for which you operate. And there are 3 requirements to high reliability, as you'll see in the blue box here. One is having competent and engaged leaders. And those are two separate things that we're asking of leaders. You can be very engaged but not so competent. And so these are those willing people but are not able. And you can also be able but not willing, and we want both. We want willing and able leaders. We want a culture of safety, and we want robust process improvement. And when those three requirements are in place, we can start to push the organization to actually behave differently. And there are 5 behaviors of high reliability, and 3 are related to anticipation of things that happen, and 2 are related to containing things that happen. And so this whole concept of being highly reliable is really anticipating and managing for when things go wrong, because they will. It's healthcare, it's complex, and we deal with a lot of types of work that are problem prone and high risk. And so these 5 behaviors here listed, once they are quantified and actually demonstrated within the organization, it will lead to an awareness. And this is a business awareness as the organization moves through this shift in their mental model. And when you have a different sense of awareness of yourself and your contributions into the system, you can see that organizational impact, and that's going to be quantified through the highly reliable processes, which ultimately should result in exceptionally safe and consistently high healthcare. So that's a super high view of high reliability, but this is what it looks like as a journey and an evolution from patient-centered care all the way down the pipe that we just spoke about. So you'll see here, there's an expectation that we do patient-centered care, and we know what that is and we know what that means. And what it means is the old school rules have to change, and we have to start playing by a new set of rules. And when we do that, we change our behaviors and we change our attitude. And the attitude becomes rooted in those high reliability concepts. And you'll start seeing those workflows shift and outcomes be resulted from that. But ultimately, in order to do this, I think we all know we have to have the right tools. We have to have the tools that allow us to be successful and that we're able to use across phases of care in order to assist us through that journey. And this toolbox could be longer. I've pulled out 3 tools here that I find to be highly important on this journey. And obviously the first one is related to communication. I put knowledge up here, and that relates to the competency of the leaders and the caregivers, in addition to our patients being knowledgeable. And then the third one would be related to information exchange, and that can be just the simple process of exchanging information, but also having the structural components in place that allow information exchange to actually happen. So that was kind of the opening there, the premise, the conceptual model that leads us into talking about care team communication and what the impact of that is on outcomes, experience, and cost. And I can't go any farther in talking about the role of communication without really taking a moment here to acknowledge its role on medical errors and patient harm in healthcare industry. And so not only is medical errors a huge financial burden to the industry, but it's also on the ranking as the 3rd leading cause of death in the United States. And, you know, these are deaths that have attributable causes associated with them. And in my experience, medical errors are not reported more than they are reported. And so if we were able to quantify the true depth and impact of medical errors, I just wonder if it would be higher than the 3rd leading cause of death. But I'd make a pit stop on this slide to just demonstrate that the depth of the problem here in medical errors is huge. It costs us a lot of money. It's highly inefficient and ineffective as far as meeting the goals for the patient, but it's also killing people. And most of them are preventable. And I'll tell you that the quote here on the bottom of the screen really resonates with me, because it says, extensive research has shown that no matter how knowledgeable a clinician might be, if he or she is not open to good communication with the patient, they are of no help at all. And so this really kind of speaks to the role of communication on medical errors, and that it really doesn't matter what you bring to the table and the accolades and the credentials that you have. If you're a poor communicator, you're going to end up causing harm to your patients, and you're not going to get those outcomes that you're seeking to truly develop a healing relationship with the patient. So we have a few more stats on communication as in the role of medical errors and the healthcare industry. So when team members don't effectively communicate, I think the outcome is obvious, but some of these things that happen is critical information is lacking to the care team, misinterpretation of information is injected into the scenario, orders are unclear, and more importantly, as we're talking about changes in level of care and transitions, when the patient changes status and acuity, those things are overlooked when communication isn't in an optimal format. I already mentioned about the leading causes of death, and another interesting factoid about this is that the Joint Commission keeps a list of all sentinel events that are voluntarily reported to them, or that they learn through by a complaint or an incident being anonymously given to them, and they analyze those for root cause. And it's to this day, for the past 10 or 11 years, communication failures are still the leading root cause of sentinel events reported over the past decade. And I keep waiting for this to move places on the list, but it still is the leading cause of all sentinel events. It's the #1 cause for things such as delays in treatment, and it's the #2 cause for operative and postoperative events and even fatal falls. So this is striking information regarding the impact of communication on the quality of care, but more importantly, harm to patients. So I want to now kind of zoom in a level deeper. We've talked about the care models and the role of communication and making those so. Now I'd like to get into perhaps the most complex process in the hospital, and that would be transitions of care. So what is transitions of care? Just very simply, it's talking about the movement of a patient from one setting to another. It can include hospitals, it can include primary care offices, it can include any type of setting, but it really speaks to the movement of those patients between phases of care, facilities, and care teams. Transitions of care increase the risk of adverse events due to the potential of miscommunication, because as the patient makes those stops and collects those milestones in their healthcare journey, they're being introduced to different environments, care teams, cultures, and competencies along each stop, along each way. The hospital discharge process, any of us working in the hospital setting knows that it is one of the most complex processes and one of the most significant times of vulnerability for patients. And it is a huge transition of care. From the hospital, patients can go to a SNF, they can go home, they can go to rehab, they can go home with home care. There's a multitude of packages to be put together and a lot of coordination that's required. Safe and effective transfer of responsibility for patients' medical care not only relies on the effective of the provider and the care team communication, but it also relies on the patient's comprehension of their discharge instructions. I don't know about you, but my observation of discharge processes include a packet of information that's printed. It can be 20, 25 pages long. It's put in a folder, and it's given to the patient within 1 to 2 hours before they actually leave. And in addition, they're also coordinating their prescriptions, their transportation, they're getting dressed, who's going to meet them at home, so on and so forth. And so if we know that safe and effective transfer of responsibility requires the patients to comprehend their discharge instructions, I might go out on a limb and say we don't do such a good job at that. So transitions of care for a real-time scenario looks something like this, and this is the same example I used in the previous webinar, but I think it's relevant, particularly around this time of year, where a patient might not be feeling so good. They go see their primary care provider or even an urgent care clinic, and they're diagnosed with pneumonia, and it's decided they need an inpatient stay to support their recovery. They are admitted on the inpatient side of the house, and they haven't been feeling well for a while. They're a little bit weak. The blood pressure drops, and of course, patients get out of bed and try to do things that they normally would do at home, but they try to do that when their strength and health is compromised. So this patient gets out of bed, the low blood pressure gives them some vertigo, and they fall and break their hip, and then need to be discharged to a nursing rehab facility for recovery, and then they go home with a visiting care nurse. So if you look at the journey that this patient, this very example patient, but very realistic in our settings, if you look at the journey that this patient goes on, they're being transferred to many different care teams, many different settings, and I can't imagine the amount of communication, standardization of clinical content, discharge instructions, prescriptions, care plans, and patient care goals that is required to be seamlessly and accurately and timely handed off from one setting to the next. I found an interesting statistic about how many people touch patients while they're in the hospital, and this is a very conservative estimate, but one study showed that medical patients, while they're on an inpatient stay, encounter around 25 people during their inpatient visit, and this is over the course of a 2 to 3 day stay. Now, of course, if the length of stay is prolonged, it's more than that, but if you imagine if it's 25 people in the hospital, maybe it's 5 in the clinic, maybe it's 25 or 30 in rehab, as the time goes on, they're encountering 100 or more people just to take care of their one incident that they need some healthcare attention for, which begs the question of how are all these people communicating with each other and ensuring that they're all working towards the same common goals to benefit the patient, because again, we are functioning under a patient-centered care model. So this is kind of a summary slide here in transitions of care. It is one of, if not the most, high-touch, complex, and communication contingent processes in the healthcare setting. Poor communication during handoffs and the transfer of caregiver responsibility leads to a multitude of outcome, experience, and cost implications. So let's talk about what those implications are. Some of the impact of poor transitions of care. Transitions of care are directly correlated with hospital readmission rates and the costs associated with that. And so when transitions of care are not seamless and of high quality, you can almost guarantee you'll see an impact on readmissions, because those patients are going to come back because they were not handed off well, they didn't understand their care plan, they didn't follow up appropriately, and they just didn't take things as seriously as you had hoped them to. The second bullet here just really is shocking to me. 80% of serious medical errors involve miscommunication during the handoff between medical providers. Hard to believe, but when you sit and think about it, my observation has been medical providers of different disciplines don't integrate well together. They don't talk to each other, they don't round together, and they don't plan together. And so, gosh, maybe this is true. Problematic transitions occur from and to virtually every type of healthcare setting, but it's especially when they leave the hospital into another setting or even at home, because they just had an acute care episode, perhaps their medication regimen changed, and they really need an extra padding of care when they're leaving the hospital to the next phase. Now, this last bullet here is no secret to any of us. The federal government has taken notice. Readmission rates are penalized, and transitions of care are now also going to be penalized. If you aren't aware of that, I'm going to speak about that next. So here we are with the value-based purchasing program for fiscal year 2017, which just actually wrapped up at the end of this September. And so if you look at the allocations on the VBP program, you can see that there's 5 categories for that program. You have a small slice of the pie for core measure related metrics. You have patient experience. You have outcomes, which are mostly mortality outcomes. Then you have safety events, which is the PSI 90 from AHRQ, and you have a handful of infections that we report through the CDC. And then you have 25% of the pie that's related to one metric, and that's average spending per Medicare beneficiary. So what this all means is 25% of 2% for 2017 was allocated to patient experience. And if you look in the peach box, you'll see that a lot of that is asking questions about communication, and it's asking them from the patient's point of view. Did your nurses communicate with you? Did your doctors communicate with you? Were you communicated to about your medications? Did you understand your discharge instructions? So we have a quarter of the pie that's being allocated to just trying to quantify communication practices alone, and the source for validating this is our patients. As we know, this average spending per Medicare beneficiary, being another 25%, really is just measuring utilization of healthcare services. So when patients are readmitted, this ratio would go up. When they stay in the hospital too long, this ratio goes up. And when they break their hip because they were admitted for pneumonia, this ratio will go up. So it's measuring how well we hand off and how well we communicate with each other, but in a different way, on a more outcome basis way. If you're not familiar with VBP, it's kind of a little thorn in the side for many of us because, as you'll see here, this program, the payment adjustments were being applied to discharges from October 2016 to September 2017. But their performance was measured from 2013 to 2015. So how you performed 2 years ago will impact how much you get paid on this year. And so if you're not on the ball with this, if you're not ahead of the game, you'll be chasing your tail for 2 years before you catch up. So this just wrapped up in September, like I said, and now we're in fiscal year 2018. The 2% reduction penalty is still in place, but you see the pie has balanced out a little bit, and we have finally gotten rid of core measures in the value-based purchasing program. And now it's a quarter split between the other 4 categories. But you'll notice we have a new metric introduced into the patient experience pie, and that is transitions of care. So now the way that our patients report how well they were transitioned, how well they feel we handed them off, and how they is being quantified in the value-based purchasing program. And again, performance was 2015 to 2017. So they began measuring this 2 years ago, and it will be applied on discharges from now through September 2018. The transitions of care component of the value-based purchasing program is intact through 2021, and that's as far ahead as they have prognosticated the allocations to the program. So it's not going anywhere for the next few years. But if you think about it, your performance in 2018 will impact your payment in 2021. Now, we can't just talk about value-based purchasing because we just learned that transitions of care is directly correlated with readmissions. And there is another program called the Readmissions Reduction Program that has a 3% reduction amount for particular diagnoses. But if we look at this, pneumonia, heart failure, heart attack, COPD, hip and knee replacements, and coronary bypass, this is really accounting for a big majority of the hospital population. I mention this because this is all connected, and unfortunately, if a patient is readmitted to the hospital, you could get a penalty in the readmission reduction program, but you can also get a penalty in your Medicare spending per beneficiary, and they probably aren't going to score their transitions of care and communication scores very well either. So one poor outcome is dinged, if you will, in multiple categories. So it behooves us to get our act together on this stuff, because we won't be able to balance it out when one thing happens and we get penalized 3 different or more times for it. Now, if we look at this in a compounding growth rate, if you will, I've outlined this for 3 years, and I went 1 year back to see you could see where the industry is transitioning. So, you hear a lot of people talk about the transition from volume to value. And you see this in the payment programs too, because even the payment programs are seeking to become more patient-centered. So the value-based purchasing program, you'll see from 2016 to 2018, it's increased in its percentage of penalty, but the metrics are decreasing. The amount of things you have to do are decreasing, so they're going to hold more weight. And where you'll see the metrics increasing on readmissions and hospital-acquired conditions is really showing that shift from process metrics to outcome metrics. We want to measure less of your process and penalize you at least on less of your process, and we want to penalize you more on the way that outcomes are being had from the patient's perspective. Because ideally, if you're doing the right processes, you should achieve the right outcomes. And this is the rationale behind why core measures has also finally been removed from value-based purchasing, because this idea behind checking a box, save a life, we should see come into fruition through some of these programs. So we are at a 6% total reduction. This is a penalty. This is not an incentive. This is actually taken out of your revenue. It is not a bonus. And you can see that how many metrics are included in each. But the real story here is on what this means in dollars. And so this is just an example of a $1 billion revenue hospital and what it could mean to the bottom dollar to have all these programs at risk should you not perform to the standard that avoids you from getting penalty. And you can kind of see what this looks like. The withholding amount is staying at the 6% through 2021. And so at least this many dollars will be at risk from here for the next several years. So there are some solutions that can be deployed for improving transitions of care. And now we know how deep and wide transitions of care impacts cost and outcomes and patient experience. But the one I'll focus on is really on communication, real-time communication within the hospital setting and or from the home setting to primary care regarding changes in condition, social barriers that are existing or new, the status of their recovery. All of that, communicating about that can actually prevent readmissions. We see that in the literature, and it promotes successful self-care for the patient and their family, which is really what makes them satisfied. It's really what makes them happy, is to be healed and then to be able to take control of their health care. Now, if we put this all together, this is what it looks like. So we have to talk about structure first. Structure is creating the ability to do the right thing. And the structural components are the culture, having the right tools in the toolbox to communicate in real time and accurately and being patient-centered, and handing power back over to our patients, not only for their health, but for their information. If we have the right structural components in place to do the right thing, then the process will show evidence of knowing what to do. And knowing what to do is really those behaviors we spoke about earlier, the team-based care models and interdisciplinary care team, and actually being able to make real-time decisions because you were fully informed and communicated with through the tools that exist in your structure. And finally, if we know what to do, then we're going to be doing, and we're going to see those outcomes that we want to see. It's going to be an error-free practice environment, financial stewardship, and having exceptionally safe and high-quality health care. So that concludes my overview. We started really big and tried to zoom in on a lot of detailed things. And I appreciate the time and attention and would be happy to entertain any questions you have at this point.
Trisha, thank you so much. That was an amazing presentation. You were catching everyone's attention when you really laid out the monetary penalties that can happen, and that what you're doing today can affect your income 2 years from now. And sort of to that point, I actually have a question. Is there a way to go back to the authorities and let them know that you've made improvements to mitigate the penalties, or are you just stuck until the next reporting period?
From this perspective, you're kind of stuck. The value-based purchasing program isn't the only place where these metrics are quantified. You have CMS star ratings, you have leapfrog surveys, you have centers of excellence designation, and so what I'd say is those might be a little bit more real-time, where you would be able to take credit for work being done, but from a financial perspective, it's a one and done, and they're going to shave it off your revenue.
Wow. So hospitals really need to be paying attention to this.
Yeah.
So how far along do you think most hospitals are in this process? Do you think they're where they're supposed to be, a little behind?
In my experience, they're almost always behind. And that's because I think executive teams struggle with the volume to value transition. The quality folks, the patient safety professionals are really focused on value and safety and outcome improvement. And the business side of the house is traditionally more focused on growth and network and increasing profitability. And somewhere in between, a balance needs to be struck where we're doing a little bit of both, and we're collaborating and really integrating strategic planning with operational improvement, and it all needs to be at the same table. And unfortunately, at least in my observations, very rarely is it.
And I did want to cover that Everbridge is known as the largest provider of emergency notification services for healthcare in the United States. We cover over 23% of all hospital beds in the U.S., and actually I think that's over 24% now. So if you are at a facility that uses Everbridge, there's a very good shot, especially with the CMS Emergency Preparedness Guidelines, that all of your hospital employees are already on the system. So if you are thinking about adding clinical communication best practices into place, you're probably already paying for a large portion of what you need, and it's really just a matter of setting up clinical lists that you can work together around patient care. And to Trisha's presentation, what we do is patient-centered as well. We consider the patient the hub, and all of the information coming into care for that patient is handled through that centralized patient ID. So with that, we're going to move over into a couple of questions. If somebody is behind, what do you recommend? Somebody comes to you and they're like, we haven't really done anything. What are some critical first steps that you see hospitals overlooking that they really need to go back and make sure that they've done?
I guess the first step would be to spread it all out and try not to boil the ocean. When you're behind, and you can have 50 or more metrics crashing down on top of you. And there's an exercise to prioritize what you get the biggest bang for the buck, if you will. So the size of the patient population affected, the effort required to deploy the improvement, and the financial gains that would be expected through those efforts. And you typically find folks seeking some outside perspective to make some of those things happen, because when you're in the thick of it, and I've been there before too, it's hard to see the trees through the forest, and sometimes it helps to have a fresh perspective to help you prioritize where you're at, what you're good at, what you can leverage to improve other things, and what things can we accept suboptimal performance on at the moment to allow us to prioritize our efforts and not become a victim of that law of diminishing return in an attempt to do too many things at the same time.
Okay. Is that checklist available somewhere?
It's not a cookbook checklist for sure. What I mean is it's an individual basis, and having an external opinion on that has proven to be pretty useful to kind of help synergize the competing priorities and stakeholders at the table. So it's not really a checklist per se, but more of an expert opinion that folks bring in.
Okay, thank you. And I think we're going to go with one final question, and that is clinician buy-in. How do you approach clinicians on doing the volume to value care change?
And that's a pretty difficult one because a lot of providers are still on a fee-for-service model, while organizations are on performance-based reimbursement model. But it can be done, and it is done. There's a lot of clinical integration contracts that can be set up to integrate outcome incentives in the provider package. I think, at least in my experience, I have found that when providers are informed and really understand the motives behind the volume to value transition, it's not hard to get them to buy in. But on the surface, and unfortunately, it has a bad name in the medical community as being a bureaucratic effort, and it's just not. And so I think it's our responsibility as hospital leaders and other clinical professionals to get rid of the fake news, if you will, on this volume to value shift and really show it for what it is and show how the role of collaboration can move us forward to where we all want to be in the healthcare industry.
Wow, that was a great last thing to say. So with that, we are going to wrap up. Trisha, thank you very much for all of the information, both in today's webinar and the one we had a couple of weeks ago. Thank all of you in our audience for attending today. It was greatly appreciated, and we look forward to seeing everyone soon.